Welcome to the Berkeley City College Science Seminar Series. We're joined tonight by Dr. Kevin Stone. These talks are sponsored by the California Institute of Regenerative Medicine, which also funds students excelling in our biotechnology program and 10-month internships across the state, furthering the fields of stem cell biology and regenerative medicine. If you'd like more information on the biotechnology program or the awards for stem cell research, please visit our website, which is at the top of every flyer, where you can also find our schedule of upcoming speakers, videos of past talks, and sign up for our mailing list. Dr. Kevin Stone was trained at Harvard in internal medicine and orthopedic surgery, and at Stanford in general surgery. He is an orthopedic surgeon at the Stone Clinic, which focuses on knee and shoulder injuries. As the chairman of the Stone Research Foundation, he has pioneered advanced surgical and tissue regeneration techniques for orthopedic sports medicine. These include cartilage replacement and regeneration, ligament repair and reconstruction, and techniques to prevent osteoarthritic degeneration. He holds approximately 50 US patents on innovations to improve healthcare. Dr. Stone is also a successful entrepreneur, founding publicly traded companies focusing on xenotransplantation, that is transplantation of tissues from heterogeneous species, which would be an unrealistic endeavor if not for the techniques pioneered by Dr. Stone to strip the tissues of antigens that would otherwise cause a severe host immune response. Furthermore, Dr. Stone has founded the company Joint Juice, which is a glucosamine supplement that can be found nationally at Costco, Walgreens, and Walmart, and is now, in fact, the widest distributed supplement in America. Dr. Stone has also served as a physician of many athletic teams and ballets, including the U.S. ski team and the U.S. Olympic Training Center. So it's my great pleasure to introduce to you tonight Dr. Kevin Stone.
First of all, thank you for having me. It's a huge pleasure and honor to be here. And it's a challenging group to speak to because you're so diverse, both in ages and interests and in science background and personal interest in the subject. And so the talk I put together is pretty heavily weighted on the science side. But I'm happy to ask and answer as many questions we possibly can after, and so don't be inhibited that any question is fair game. So just for my own personal story, so I injured my knee playing soccer in college. I admired the surgeon who operated on it, and unfortunately I didn't admire what he did because he took out the meniscus cartilage, which is the key shock absorber inside the knee. But he was such a cool guy and wandering around the training room, and I thought, you know, gee, if I could ever do that, it would be great. And so that's what inspired me to become an orthopedic surgeon. And then my next mentor said to me, you know, if you could ever figure out a way to replace that meniscus cartilage, the shock absorber inside the knee, you'd make a big contribution to orthopedics. And so young and brash, I said, great, I'll do that. You pay for it. And he said, okay. And so that's how we got started. And so I spent the first few years of my orthopedic research career in the Countway Library in Boston, and those are the days when you put a nickel or a quarter into the smelly Xerox machine and Xeroxed the entire world's literature on the meniscus cartilage, the shock absorber in the knee, and read that for 2 years and tried to figure out whether or not I could find an artificial material that would match the biomechanical and biologic components that I read in the literature were what made up that shock absorber inside your knee. And I gave talks at DuPont and Thermetics, all these companies back then, looking for some material like Teflon that I could put inside someone's knee, and it turned out there really wasn't one. There was nothing soft enough to go inside the knee joint and durable enough to withstand the forces of the knee joint, and that wouldn't break down and damage the surrounding articular cartilage. And so finally, by 1986 or so, having spent a few years doing this, I decided, you know, if I can't replace this shock absorber inside your knee, maybe I could regrow it. And so since we're all made up of collagen, I decided a collagen scaffold would be what I would want to have. And so I designed the first collagen regeneration template for regrowing the meniscus cartilage. And that became my first major research project. I got funded by, I got funded by the Letterman Army Institute of Research, which used to be in the Presidio in San Francisco. And one of the good things to know about funding for those of you looking for it is that if you apply to the military and you find a general who has the problem that you're trying to study, So all I had to do was find a general with a sore knee, and I did, and I was funded then continuously through the Army until the Army, in its wisdom, moved the Letterman Army Institute of Research to San Antonio and tore down the building in the Presidio, which was a disaster and such a loss. But so I lost my research site at the time. But in any case, it got me going in research around the knee. So these little things that happen to you in your lives, for those who are students and looking at, how do I get inspired, where do I go, how do I figure out what to study, what's important to me, what turns you on, I always counsel people just look at self-interest first. What do you need? Or what does your family need or your community need? Just sort of look at something that affects you quite a bit, and more than likely you'll be pretty passionate about it, and it will be worth spending your life and your times and your nights and your weekends and your career trying to figure out how to solve. And if you pick a problem that's big enough and has a big enough impact and is challenging enough, it'll inspire you for your entire career. And also you'll have all the rewards, the good feeling of making a real contribution to the world. And so I decided if I was going to be an orthopedic surgeon, I wanted to care for people like me, people who did the sports I like to play and do the things I like to do and had the same problems I had that I wanted to solve. And so what I'm going to do in this talk is I'm going to take you through a series of problems that relate to the knee that inspired me and that I really put my head down and tried to solve. It's a very biased talk, so beware that a lot of things I may say are not generally approved throughout the orthopedic community or done elsewhere. It's really biased towards what turned me on, what have I studied, what have I made contributions in, what do I think is right. And I do that in part because it's what comes from within me and what I'm passionate about, and I do it in part to help hopefully inspire you to look inside yourselves and think about what you might be passionate about. So with that, let me show you how we try to do that. So first of all, as a physician, if you're coming to me as a patient, I need to care for you from whatever age you start out with to hopefully you drop dead at 100 playing some sport you love to do. And so I need to think about how to care for you through all the stages of adolescence and midlife to retirement. And part of doing that is kind of a continuum of care. How many things can I do for you, and how few things do I do to you? And if I can optimize the things I do for you, then I don't have to operate on you. And then we try to do these things by looking at a number of non-surgical treatments, and then we'll get into what the surgical ones are as well. So thinking about this talk, it's going to be stage one, all my exercise, non-surgical things, just to explain to you a little bit how we keep your joints healthy. And then the arthroscopic things, the things I do as an outpatient, and then maybe some of the bigger open things if we have enough time. And so the first thing are these exercise treatments, and exercise is the most important treatment that I can do for you. If I can inspire my patients to see themselves as athletes in training and not patients in rehab, then they'll do so much better. So if I can use your knee injury or your ankle injury or shoulder injury as an excuse to help you start to get fitter, faster, and stronger, as we like to say, then we feel like we can contribute to you. And we can do that by looking at all the tools that we have in the clinic to help you, whether it's a stationary bike or balance or proprioception. There's no patient, there's no arthritic patient who comes to see me with an arthritic knee who hasn't been walking with that arthritic knee for a while. So now they've gotten a bad hip, or they've got weak through their core or weak through their spine. They've compensated for that bad knee. And if I just treat their knee and ignore all the rest of them, my therapy won't be anywhere near as good, and I won't achieve that goal of helping them to get back fitter, faster, and stronger than they started out. And so all of these things, strength training, stretching, soft tissue mobilization, these are all the things our superb physical therapists in our clinic work with every patient on. And so the importance of exercise, it supports healthy body weight, helps relieve stress on the joint, improves joint stability, decreases pain. Most importantly, I'm essentially a drug pusher. And the drugs that I push on my patients are endorphins and pheromones and adrenaline, good hormones from exercise, all those good feelings you get when you exercise and you sweat. And if I can get you addicted to those, if I can convince you to exercise every day, not just 3 days a week, but every day, then you get all those good drugs flowing through your body, you get addicted to them, and you miss it when you miss that day. And if I can get you there, then I can help you on the way to being better and fitter and faster and stronger. And so there are a number of non-surgical techniques. So nutrition consultation, we optimize people's weight because you take 1 to 3 million steps per year at up to 5 times your body weight. And so if you're 10 pounds overweight, or if you lose 10 pounds, that can be up to 50 pounds per step, 2 to 3 million times per year. It's a phenomenal amount of force reduction on your joints by just optimizing your weight. And then there are other little tricks, heel wedges and braces and exercise, and glucosamine is a supplement that we believe helps lubricate the joint. Non-steroidal anti-inflammatories we tend not to use very much anymore. PRP is a growth factor that we use to try to create an anabolic effect inside the joint. Viscosupplementation is the lubrication that we now put back into people's joints. And so how do we get people to lose weight? Well, the first thing is hydration. And every one of you sitting here are nowhere near as optimized. You're relatively dehydrated. You slept all night, you woke up in the morning, you drank a cup of coffee, you didn't drink water at night, you tend not to drink enough water during the day. All of your brain cells work better with water, as does every cell in your body. And so if I can get you to reach for a tall glass of water every hour, you'll hydrate better than if you're drinking anything else. And if you're trying to lose weight, if I can get you to reach for 2 tall glasses of water before you lift the fork, it's portion control. It's the cheapest, easiest diet around, and it actually works really well. And so the importance of nutrition for your joints. So of all the options out there, glucosamine is the only one with good data that actually seems to help lubricate the joint and decrease stiffness. And glucosamine we believe in, and I'm biased. I started a company to help distribute glucosamine because people all said to me, well, I hate taking those huge horse pills. Can't you find a better way for us to get in enough glucosamine? And so we designed a beverage to do that. In viscosupplementation, you'll hear a lot about that. We put lubrication back in people's joints. It's just like putting a little thicker oil in their joint, and helps the joint feel better and work better for time. In an arthritic joint, it's a very easy, safe way to decrease pain without having any harmful side effects. In non-steroidals, the ibuprofen you used to see all the athletes taking after an injury, and many of you have taken for a long time, we really diminish their use now because there's very good data that inhibits collagen formation, inhibits bone formation. When we look at all the elderly people who used to have hip fractures from falling down, and we wonder how many of those did we induce by having them on non-steroidal anti-inflammatories for years, which really inhibit bone formation. And so if you've torn your ankle ligament, do I really want to put you on a non-steroidal which inhibits the collagen formation that I'm trying to get that ligament to knit back together? It's probably not the right thing to do anymore. Ice and compression, Tylenol, elevation, soft tissue massage are probably much safer and better. But sometimes, despite all these non-operative things, I have to take you to surgery if you've torn things that need to be repaired. And so let's go through my bias. We'll go through a few of the things that I spend my time doing research on. It's not meant to be a full talk on knee surgery, of course. And so inside the joint, the things that I can put back, many people have lost that meniscus cartilage. Remember the one that I focused on regrowing? Well, now we're doing a lot of replacing that meniscus cartilage with a donor graft, an allograft. Or if you've blown out your ligament from skiing and your knee's unstable, it's like a car that's out of line, so it's not tracking properly and it wears out faster. So we want to rebuild your ligament. And traditionally, people have rebuilt ligaments by taking one part of your knee, your patellar tendon or your hamstring, to rebuild the ligament. And what a tragedy that we have to hurt one part of the knee to rebuild the other. And so now we do a lot more donor ligament, allograft ligament, and I'm going to show you our research on how we can use animal tissue rather than using donor tissue. And lastly, articular cartilage, the bearing surface of the joint. When you get arthritis, it's wearing away of that bearing surface of the joint. So you crack open the chicken wing, the white shiny surface, that's articular cartilage. When you get arthritis, osteoarthritis or traumatic arthritis, it's a wearing away of that white shiny surface down to the bone. And so we want to regrow that surface, and we've developed ways to do that now, both in young people who are injured and older people who are arthritic. So let's just focus on a couple of these. So ACL reconstruction, where we put a ligament back up in the knee after the athlete has ruptured it. Well, I don't want to have to take part of your knee to do it. I want to take an animal tissue. And why do I want to take an animal tissue rather than a donor human? Well, animal tissue, if I take it from pig, it's young, healthy, and strong every single time. It's a product off the shelf. Where if I take it from donor tissue, I'm relying on essentially young people falling off their motorcycle and donating that tissue, and the supply of young people falling off their motorcycle isn't that high, as well as there's so many variations in risk from those donors. So I'd like to have an ideal donor. I'd like to have an ideal xenograft, or xeno from animals to human in this case. I want it to be functional at the time of implantation, and this is my design criteria for those of you who are in the science stage of designing products. So my design criteria for this ligament was functional at the time of implantation, biocompatible, immunocompatible, meaning not rejected, sterile, viral safety, cellular ingrowth scaffold, and have it remodel. So let me show you how we attack these problems. Now remember, whenever you say, hey, I'm going to do a new thing in science, you're going to go through the 3 stages that all of you have gone through in life. Whether you just proposed a simple project to your parents or you proposed a major new revolutionary thing. First, your peers are going to ridicule the idea. Oh, that's damn stupid. You're never going to do that. Then they're going to be violently opposed because they didn't invent it in their place. And then lastly, if you do good enough science and you take enough time, eventually you hopefully will have acceptance of your idea and publication and worldwide use. And so we've been through all those stages. So let me explain initially why people say, oh, well, you can't use animal tissue in people. You can't use animal tissue in people because all animal tissue has a specific carbohydrate called a galactosyl carbohydrate that makes it different from people, because about 20 million years ago there was this transformation that lost the enzyme that converted the ability to eliminate that epitope, alpha-galactosidase. And so that epitope causes rejection in any animal put into people other than old world primates. Now, the only way you can use animal tissue in people, for instance, some people here may have had a pig heart valve, is that if you fill it with glutaraldehyde, a cross-linking agent, you can block that epitope. You can block the attack of the immune system on that epitope. But that makes the tissue brittle and fail, which is why young people don't get a pig heart valve. They get a mechanical one. Old people get a pig heart valve because by the time it breaks down, they most likely won't have survived. So we can't do that for a ligament. We need it to be moldable. We need the body to grow into it. We can't have rejection. We can't make it brittle with an aldehyde. And so the only way we could do that was to strip that carbohydrate. And so the technology that I started to develop in 1996 was using a specific enzyme to wipe out that carbohydrate through tissue. And so here's a slide just showing you that immunologic rejection, the identification of that specific GAL epitope. And then here's a little graphic explaining how if you use glutaraldehyde, you can fix all those side chains and block it, and you've got essentially an inert prosthesis like a heart valve, but we don't want to do that. What we want to do is strip that alpha-galactose, that alpha-gal epitope, using alpha-galactosidase, and create essentially a universal tissue that we can use in humans. And so then what we do is we're taking the tissue, we're stripping it with an enzyme. Now it acts like a regeneration template. We let the body's cells grow into it and remodel it into your own. And so if you ever want to do science and not have the peers in your field know about it, publish it in another field. So I published all these papers in the Journal of Transplantation rather than the Orthopedic Journal, because my co-author was an immunologist, but it kept it quite low on the radar screen for a number of years. And just to show you that what happens if you take pig tissue, I don't think there's a pointer here. If someone has a pointer, I'll take it. If not, I'll just point. So if you take pig tissue, as you see in the top, that's a meniscus there that you see in the top left slide. And if you put it into a joint, into a primate, because a primate like humans rejects all of the tissue from lower order animals because of this anti-gal antibody response. So you get all those blue cells there on that slide in the middle upper, and that's rejection response, lymphocytic reaction to that transplanted tissue. Now, if you strip the tissue of that specific epitope, the slide in the far right there, you can see the tissue remodels appropriately. That's a normal collagen maturation. And that's true not only for meniscus, we did here for bone. We put bone struts on top in a primate model, saw the rejection, treated the bone, and obviously saw the nice healing. And so we demonstrated that we could use an enzyme technique to clean animal tissue and use it for people. And so what we did for the ligament is we took a bone, patellar tendon bone, which is what you would take from a normal human to rebuild their ACL. In this case, we took it from a pig. We treated it. We demonstrated that we didn't disturb the normal collagen matrix that you see in the slides on your left, lower down there. And then we processed it in a way so that we assured sterility and strength by stripping those things and not using harmful radiation to sterilize it. And then we went through all the FDA requirements, and those of you who are interested in doing device research will learn quickly that you need to go through an entire set of criteria for the FDA to prove that your device is both safe and efficacious inside a person's knee. And these things, the sterility assurance, medical device biomaterials, biocompatibility, viral safety, pre-implantation biomechanics, are the stages that you go through, and we went through in order to prove efficacy here. And sterility assurance follows these dose mapping methods to be sure that you don't have viral or bacterial contamination. And there's an entire set of protocols for biomaterials and biocompatibility, which I'm going to show you a little bit of. Not to intimidate you, to make you say, no, I never want to take a product through the FDA, but just to show you that it is indeed doable, even though it's a very long pathway. Viral safety is a very big issue for xenograft tissues, and we had to model a number of viruses and demonstrate that the sterilization technique removed all of those types of viruses. And then biomechanically, we had to demonstrate that indeed the curves of a porcine and human ligament, when you pulled them apart, followed the same pathway, so that it was at least equally or even stronger than the human ligament. And we had to do both static and dynamic abrasion testing to be sure that if I put it in someone's knee, it wasn't going to rupture or abrade. And then we had to demonstrate the maximum strength of the Z-lig versus human bone, patellar tendon bone. Now, this is interesting in this slide in that this is age-matched, and what you can see is that human tissue degrades at about 1% per year. And so if I'm taking a human donor to rebuild a knee, if I take it from a 50-year-old, it's quite a bit weaker than if I take it from a 20-year-old, just as you would expect. But that means if I'm rebuilding 20-year-old knees, I need to find 20-year-old donors in order to keep that tissue strong. And so the beauty to using a young, healthy pig is that every time I can assure the strength of that device off the shelf. And so then we had to design the appropriate model. Now remember, I told you that I can't take animal tissue and put it in other animal tissue to demonstrate the immunologic rejection, except for old world primates and humans. And so we had to go to an old world primate model and rebuild the ACL in old world primates to demonstrate that it would maintain the strength and not be rejected. And so we did that. And we did a series of test groups over the course of 12 months, looking at the grafts for all the, the biocompatibility, histology, and biomechanical parameters. And so we also needed to look at the serology. How much did the body try to reject that tissue? And so here you'd see an untreated one where there'd be a large rejection response, and over time you'd see in the treated ones that there was a very muted response or recognition of the xenograft tissue. And then here you can see a native ACL, and this is, sorry I don't have a pointer. This is the tissue in the middle, this is the ACL, it's the femoral condyle here, and there's when we put in a pig ACL into this primate knee, pig patellar tendon into this primate knee. And it looks nice and healthy and no big red rejection response. And then the histology, looking at here at 2 months, looking at rhesus allograft, so primate to primate, it shows how the cells migrate into the tissue, and then the slide on the far right, the bone in the tunnel. Untreated porcine, there's a big rejection response, all those little blue dots, and then the treated one is much more normal and a normal maturation over time. So the 2-month histology showed us what we expected, that the pig tissue would not be rejected. And then we looked at 6 months, and looking at, here's an entire femur to tibia, and that's the graft in the middle. And it's a beautiful slide of the Sharpie's fibers, the fibers of collagen mating to the bone inside the joint, showing the normal healing. And that mating to bone is so important so that when you put stress on it, the ligament itself is strong enough and doesn't pull out of the joint. And at 6 months, we saw what we'd expect, a maturation of the tissue. And at 12 months, the same thing. And here you see these beautiful slides of the collagen fitting right into the bone on each of these slides. And that's the kind of maturation we wanted to see, xenograft tissue into a primate knee. And so the primate at 12 months, again, appropriate. And so then what we want to do is look at the postmortem biomechanics. How strong is it after it's lived inside someone's knee for a while? And so we had to do structural and material testing here. I'll show you how that works. You create a jig and test the graft. And looking at the biomechanical properties, we'll show you how this pulls apart. First of all, these are strain rate curves, and it shows that the pig ruptured one matches what we would expect for a normal human. And then I'll show you how it pulls apart. So here, the slide on the top, if you ruptured your ACL, and sorry for those of you in the audience who have, this is what happens. The knee's pulling apart, the ligament essentially degloves and the ligament ruptures. And so we wanted to be sure that the ones we'd put into the primate knee would function in the same way or rupture in the same way. And indeed they do. As you pull them apart, they kind of deglove there, and that's the rupture of the ACL. And those of you who have done it, when you heard the pop, that's the pop that actually occurred inside your knee. Sorry to do that to you. And so in any case, we compared this to what's been published in the literature and a number of other animal models to show that this would be at least as strong as what had been seen in other animal models. And so in summary, we concluded that, again, you could use these pig tissues treated appropriately in the primate knee. Now you'll say that's great for primates, but what about people? And so we go to the FDA with all of this data, and we asked them to do a pilot human clinical trial, which we did in our clinic here in San Francisco, with the first 10 patients. And so here's the bone, patellar tendon bone, and here it is put inside a knee. And my patients called it the pig leg, and so they came in to get a pig leg in their knee. And this was a pilot investigation just for safety and for technical feasibility, not for efficacy. And in 10 patients, you can't tell does something really work or not. It's a safety trial to permit you to go to a wide clinical trial, and that's the clinical design that we did. And so this is a non-randomized human clinical trial that we designed based on our primate work. And so the mean age in this group was 41. Patient selection was not so good because I picked some professional athletes and some very difficult knees. I should have picked some very quiescent people who weren't going to test it so much, and I'll show you what happens when you do that. So unfortunately, we had an unfortunate trauma in that patients, you know, if their knees feel so good, they don't follow our careful rehab program sometimes. And they, unfortunately, will go out and re-rupture my precious device that I put in their knee. Now, that's bad luck for their knee, but it actually is good luck for the study because you actually get to see what happens to that ligament. So here's one where that's inside the knee, and this is an MRI. So this is the femur and the tibia. This is the screw that holds the ligament in place. And then here in the middle is the ACL that we've grafted, and that's the appropriate way that it should look on MRI. And then, unfortunately, in my professional patients, they go and do that during the early post-op period, and sometimes they don't land so perfectly. And so this poor guy ruptured his cruciate ligament, and that's our pig ligament. And what he did is he ruptured part of it, not all of it. And so that gave us a chance to look back inside his knee and look at the histology and determine that, indeed, there was no evidence of a rejection response. So our thesis that if we could strip away these epitopes, that we could humanize the tissue, in fact, was true. And what I did, because he was in the middle of a competitive career, I did not rebuild him at that time. I left the portion of the graft that's still intact. And that gave us a chance when he came back 13 months later after his season to get a new ligament in, to look back in his knee and actually look at the remaining graft that we had left in place. And indeed, it's quiet, mature, and growing nicely, and gave us great confidence that this ligament could work well, as long as they don't go re-rupture it in the early post-op period. Another patient, here we put it in, and this is a professional ski racer, and here is the MRI showing the nice graft in the middle of his knee there. And here it is looking at 108 months post-op, and that's a nice black graft going right up in the middle of his pig leg. And he's one of our poster children because he went on to win the Canadian Masters Downhill Championship on his pig leg and was very happy to have it. So just our pilot study results were good enough to permit us to go back to the FDA and say, hey, we'd like to do a wide clinical trial. And in fact, we did the wide clinical trial in Europe, and we just concluded one-year data on that and have submitted it for approval. And in this study, however, the data was good enough to show that the results were successful from a knee laxity point of view and from activity and function questionnaire. The patients were improved. And so the safety and implantability and preliminary efficacy data was good enough. Histology, MRI, serology, all successful for that study. And limited study in small numbers, but good enough to get to a wide clinical trial. And so now we've done a CE mark trial, which we've just concluded the first year data with 30 patients in each arm. And that's OUS in Europe, and then we'll come back to the US to do a US clinical trial. So we'll move on past this one now, and this is the FDA clinical trial. It's for 326 patients. Just to give you an idea, for those of you who are looking forward to doing these trials, it costs about $20,000 to $25,000 per patient to do a US clinical trial for a device like this. So it's an $18 to $20 million study to get funded, in case anybody has some extra funding. Okay, so just with our time, we've got about 20 minutes left, and I'll go through one more example and then open up to questions just to give you the things that we're passionate about. So remember we mentioned to you the meniscus cartilage. So here's the meniscus. Those of you who have lost your meniscus and have a sore knee, we created what we call a bio-knee program where we want to rebuild the cartilage and the meniscus and the ligament inside someone's knee rather than putting in metal and plastic if we can. So it's a biologic knee reconstruction. And we've done a study now looking at our data of doing these meniscus replacements in arthritic knees over time. And so in our first 119 patients, there's about a 79% success rate there in looking at survival of these implants at about 9.9 years. So it's a meniscus going into an arthritic knee. We can tell someone, hey, for 10 years or so, we would expect that would work pretty well and keep you playing sports on your biologically reconstructed joint. And then not only for the meniscus, if we're going to put that in an arthritic knee, we know that if we leave the raw surface rough, it will fail, so we have to graft the articular cartilage. And we do that by using the patient's own stem cells from their intercondylar notch, their own cartilage and bone. We make it into a paste. We bloody that arthritic area and then graft the paste onto it, all within the patient's knee. And that's called an articular cartilage paste graft repair. The old thought was that cartilage couldn't heal, that it was avascular and aneural. And the new thinking is that, listen, cartilage cells, chondrocytes, can grow in tissue culture. And if they can grow in tissue culture, why can't they just grow in the knee joint? And so what we did is use that principle by creating the right matrix and healing environment inside the knee joint. We created a paste graft for healing of the cartilage surface. And so here, this is what dead arthritic bone looks like. You've got a hole, and remember the cartilage should be white and shiny. You've got this arthritic area in the middle, and what we do is fracture it and then graft right into that fracture with the patient's stem cells and paste, create a bleeding site. And we got this idea from two things. Number one, when we used to do ACL reconstructions and we would open up the notch inside the knee, we often saw that that notch would heal in on its own. And I thought, well, if it can heal on its own there, maybe it can heal on in if I transplanted that. And the second thing was that in my skiers, the bigger their injury, the bigger they smash their knee, the bigger the healing response. And so in an arthritic knee, essentially the surfaces are somewhat dead. And so the thinking was, well, if I could take those surfaces and freshly fracture them, it's typical orthopedic surgeon talking, right? If you can really smash it and break it up, then I could create a whole new eruption of bleeding and blood supply and a healing response, and that's what we did. And so the prior hypothesis was these little fractures, and our expanded hypothesis was fracture it a lot and provide it with the right matrix. And so this is how we do it. We look inside the knee, we see that arthritic area, we shave it, we fracture it with an actual ice pick called an awl, and create a big bloody defect there. We harvest graft from the intercolumnar notch here, as you see, with a trephine, and take it out of the knee and put it in a little graft smasher, and in the OR just hit it with a hammer and create a paste of the stem cells and bone and cartilage. And then we take that paste and graft it back onto the surface. And we wondered, hey, does that paste actually contain stem cells or progenitor cells? And we did a study in San Diego with a lab that put the paste into a chondrogenic media, demonstrating that we did indeed have progenitor cells within that paste, both in young people and old people. We did a study in young acute chondral injuries, and we did a study in patients coming for a total knee replacement. And so in our characterization study, we were able to demonstrate that both young and old have progenitor cells that can grow new cartilage. And we demonstrated that their healing ability occurs both in the paste and in the core of bone, and that the cells are indeed progenitor cells and can become cartilage. And so then we looked at clinical results in arthritic knees. And so the slide on your right, this is an arthritic surface here. So the femur is on top. That's raw bone. My gold probe is coming in here. There's no meniscus. And then the slide here is one we've grafted and healed and put a new meniscus cartilage into. So it's white and shiny and smooth. And that's the kind of result that we wanted to see. And so we went and published that data in a clinical prospective trial looking at patients in a 2 to 12 year follow-up study. And we used a bunch of subjective questionnaires to see how well it worked. So in the first 145 patients, there were 76 medial side and 23 lateral side there. These are fairly large areas inside the knee joint. We used subjective measures over time, asking the patient to fill out questionnaires, and looked at the success rate in these very arthritic patients that we were rebuilding biologically. And pretty well overall success rate of 107 out of 125 patients during the course of this study. And so we then did a biopsy of all those patients. Back then I asked all my patients to come back for a second surgery, a second look arthroscopy and biopsy. And about 70 of these patients did that, and we sent off their biopsies for outside objective review, trying to see what type of cartilage did we regrow. And about a third of it looked to be almost nearly normal cartilage, and the rest was a mixture of repair tissue and articular cartilage. And so right now there's no other choice for rebuilding the knee biologically for patients. You can either do a joint replacement, metal and plastic, or you can do a biologic replacement if there's still enough joint space left to do so. And so the problem here is what do we then do if, and I'll sneak in one little bit more, what do we do if there's an entire surface that's worn off inside a joint? What we do today is we do a partial knee replacement with metal and plastic, or a full knee replacement. So this is a partial knee replacement where you put a metal cap on the end of the bone, a metal tray and a plastic tray here. And that's what a full knee replacement looks like when you completely replace the surfaces of the joint. And so today what happens, and if you have a part worn out one side of the joint, you'll see a metal cap comes in and covers that. And what I would really love to do is, instead of putting a metal cap on, I'd love to put an entire cartilage shell graft on top, healthy cartilage on day one. Now let me explain why that's such a problem. So in a shell graft, you would be taking a layer of articular cartilage and underlying bone out of the freezer, right? Somebody had died, they donated their knee, you carved off that graft, you put it in the freezer. And the problem is that once it's in the freezer, all the cells are dead. So you've got a dead layer of thick articular cartilage and underlying bone. So number one, how do you get it into the knee? Number two, how do you get cells into it? Number three, how do you keep it alive? Those are the challenges. And remember, I started out this talk by talking about things that are totally outside the norm and that you'll suffer some ridicule from. And this is one, you know, putting an entire new cartilage surface on a bone is one you will expect to suffer some ridicule from. Because the hurdles are huge. How do you get cells into this dead cartilage? How do you replace the arthritic surface? Could you even keep them alive? And so the tactics that we developed and are working very hard on and have not solved. So let me just explain, we're midway through this very difficult problem, and I would love to have your help and anyone here in the audience who wants to share in this kind of research. This is where we are in the state of the art of trying to rebuild knees biologically. So what we designed was a vacuum technique of sucking cells into the cartilage graft. And we demonstrated we could actually get them in there, and we even demonstrated we could keep them alive. And let me show you how. And so the first step was, okay, how do you put the graft into a knee? So we took a pig knee model, and pigs, because they're reasonably close in thickness cartilage to humans, and because you eat them so you don't feel so bad about using them in science. We always feel bad about animal research, but if you're going to use an animal model, I think that's a very reasonable model to use. So in the pig knee, we went ahead and created these defects and we implanted these fresh grafts. And so here's this graft of cartilage and bone. And then here's what a healthy joint looks like. You see the white, shiny cartilage. You guys are all now expert at white, shiny cartilage inside knees. Here's the histology of what it looks like. So the underlying bone here and the normal cartilage cap on top. And you see this nice columnar formation of cells within normal cartilage. So that's the goal of what we have to get back to if we're going to be successful in putting in a cartilage shell graft. So here's a pig knee now, and so here I've created this big trough inside the knee to replicate what would it be like in a really arthritic knee that I had to completely resurface. And so here's the model, the drawing on the right, and then here's my shell graft put inside the knee and held in place with these two little tacks that are resorbable tacks to hold it in place there. So that was our model development. Hey, how would you do it? Would it work? And so here's fresh. So I took fresh cartilage from a pig and put it into a fresh defect. And in fact, the cartilage looks pretty healthy and healed pretty well. And remember, in this case, I'm starting out with fresh live cells and live cartilage. So this is my model. How could I do this now with frozen cartilage? So we know at first we can do it, at least in fresh. And so now what we want to do is take dead cartilage and see if we can recellularize them. And so we developed, so here's just for control, a viability control. So here's what cartilage looks like. Here's the layer on the surface, the bone over here. There's no cells alive inside there. It's dead, it's frozen, the cells are dead. So what we do is and this is a viability study, a stain that stains live cells. And when they're live cells, they turn red inside the stain. So here's our control. So here what we did is we put it in our vacuum pressure technique, and we were able to suck cells all the way into the cartilage, and indeed we got them all the way into the thick articular cartilage surface. So we were pretty happy that we could do that at first. And on the viability study, you can see there's tons of them alive. So on day one, in the test tube, on the lab bench, we can suck cells in, we can get them in there, we can keep them alive. And even deep down in the deep layers, they're alive. So next you say, okay, well, cool, you can do that on the lab bench. Can you do that and put them back inside a pig knee? And so then we went back to our pig model, and here's our thin shell graft test graft, and then here's our observations. I'll just take you through a few of these because we're a little bit out of time, and then we can answer some questions. So here's our model. So here we had some perfect round dowels as one model, and then we had our seeded shell grafts here on the bottom as another. And then, and so here's what it looks like inside the knee joint itself in our clinically relevant model. So here's the defect, and then here's the shell graft in place. And then here's what it looked like healing at 20 weeks. It looks terrible. So the problem was that we can get the cell, we can figure out how to get it in, we can get cells into the graft, but they don't stay alive inside the animal knee over the course of 20 weeks. So the problem we have to solve, and we need your help for, is okay, good trick getting them in there. Here's some other ways that maybe would work to keep the cells alive inside the cartilage and therefore be an effective, complete cartilage surface replacement technique. And that's the state we're in right now, is trying to figure out that problem. And I can show you lots of slides. We did it from bone marrow. We did cells from fat. We did cultured chondrocytes. We looked at all kinds of different cell sources. None of it made a difference. So I'm going to stop right there because I can keep going forever. But I'll run out of all your time if I do. And I'll just take questions and go any direction you want to go in.
What kind of food do you give the cells so they can live? Blood?
Yeah, so inside the joint, cells are nourished by both the blood supply from the bone and the synovial fluid inside the joint. And so we don't currently do anything different than that, but if you have an anabolic or some other way to stimulate those cells to stay alive, I'm all ears.
So as usual, if you can use the microphone to ask your question, it's preferable because then we can get your question on the audio track. So let me know.
Other questions? Yeah.
Yeah, so I tore my meniscus, you can probably hear me loud. And they went in with something that looked like a Tyrannosaurus and a vacuum cleaner, clipped it out, sucked it up. Why didn't they use super glue? I thought that was what they created super glue for.
It's a really good question. So what we do in the meniscus, whenever we can save it, is we actually sew it together. And the glue that we add to it is called fibrin glue. Sometimes we add a fibrin clot, or we add PRP, which is a growth factor, helps stimulate repair. And the two criteria that I use for saving the meniscus is, number one, is the tissue healthy enough, not degenerative and beaten up? And number two, can I get a stable repair? Because if it's unstable, it'll just re-tear. So you always need to know the bias of your surgeon or the bias of your researcher. So I'm very biased towards saving those things. So I'll push the limits for my patients to try to save them, and sometimes I'll fail, but I'll really push the limit hard to try to repair those. Other surgeons don't have that bias. They might have a different bias and say, hey, it's much easier for you just to have a quick surgery where you take it out and deal with the problem later. So you always need to know the bias. Yeah. Yeah, in the back. I can repeat your question for you if you want. Go ahead.
I was interested in the clinical trials that you were doing, and I had a few questions about it. At what phase is it now with the FDA? And since it's bio versus device, I'm assuming, did you have to file for a 510K for that?
Yeah, so it's a good question. The question was, what's the stage of the different studies relative to the FDA, and what are the filings that you need to do? So for the first thing that I designed, the collagen meniscus implant, that went through its FDA device trials. There was no predicate device. A predicate means that there's some device that came beforehand that this device is just like, and if that predicate device was on the market before 1976, then you can say, hey, we're just like that, and you go through a very usually quick pathway through the FDA. If there's not a predicate device, then you have to go through what's called an IDE, a full-on investigational device exemption, which requires both a pilot study and then a wide clinical study in devices. And so for our ligament product, the xenograft ligament, that went through a pilot study in my clinic, and then it went to a wide clinical trial in Europe, and it's got approval to do a wide clinical trial in the United States, but hasn't started that trial yet. Yeah. Yep. So in the ligament study, the blinding was against allograft. So the patient received either a pig ligament or a donor human ligament. The patient didn't know. The surgeon obviously knew because he was putting it in, but the evaluator at the different time intervals didn't know. So both the patient and the evaluator were blinded. Yeah.
When you have a replacement like this, how long does the patient have to stay in bed or stay immobilized before he starts putting weight on it, or let alone go off a ski jump?
Yeah. So it depends on what the repair, the question was, how long do people, are they relatively immobilized? How long do they have to stay off it for the different procedures? And so if we're regrowing cartilage, articular cartilage, that takes time to mature. And if it's on the end of the femur on either side, then we have patients use crutches for a month and a CPM, or a continuous passive motion machine, to mold the cartilage and tell it, hey, be cartilage, don't be bone. If we're rebuilding a ligament, that a patient can weight bear on right away, because it's better for them, it's better for the muscle development to have full weight bearing. In a repair of a meniscus, it depends on how stable or unstable the repair is and what the location is, determines whether or not we use early weight bearing or not. But generally, after a month, most of these procedures can take weight bearing and activities. By 3 or 4 months, they're maturing. Most collagen tissues mature over the course of 12 months, and so they get better and better and stronger and stronger. Sometimes as they remodel, they may go through a little weakening phase and then get stronger after that. Yeah?
Is there a special properties about the big ligament as opposed to the other animals, like cows or something?
Yes. Pigs are plentiful. They're cheap. They're strong. They grow to 600 pounds, depending on the breed, in 6 to 8 months. So they create very strong ligaments. And pigs have been used for human transplantation, heart valves, insulin, skin, all kinds of applications. And so for an animal to human transplant, it makes for a very good model.
Where are you now with respect to research on shoulders?
Yeah. So my practice treats shoulder, knee, and ankle. The stage of cartilage replacement in the shoulder is nowhere near the stage that it is in the knee. While we can do some of these procedures in the shoulder, it's far behind the knee research. Yeah?
I'm curious about hyperbaric oxygen. Does that help or hurt?
Yeah, so the question is about hyperbaric oxygen. And really that gets back to our question about how do we provide nutrition to the cells. So some tissues heal better with a higher oxygen tissue tension. And some tissues heal better with a lower oxygen tissue tension. Articular cartilage may be one of those tissues that does better with lower oxygen tissue tension. So it depends on the tissue. Most soft tissue healing, most wounds, do better in a hyperbaric chamber, higher oxygen tissue tension. And so you'll find that a lot of wound care, severe burn care, and other care, they'll use hyperbaric chambers to improve the tissue healing. Yeah.
I was wondering if you could take us back through, there was a picture where the graft was recessed after.
Yes.
What exactly was occurring there? And I was also wondering if there was also a way to graft it outside of the plug, so if you could somehow attach it to the surrounding tissue.
Yeah, so it's a really good question. So what we did in that model was we created a defect and we inserted a shell graft, a little layer of bone. And what we saw in that slide and a bunch of others, which we just didn't have time to go through, is it often would recess or sink. So the underlying layer didn't support it properly. And so your question is, hey, could you do something either by supporting it better, fixing it better, building up the underlying layer better? And the answer is, I think we could. And so the next model study that we proposed, but we don't have funding for yet, would be to load the undersurface there with our paste graft technique, which we've already demonstrated works pretty well for healing, and put the shell graft on top of that. And there may be some other techniques too, better fixation, different model design. It could be a function of model design, why the cells died rather than just cell death. My real feeling though, and for all of you related to serum, the most depressing statement that I heard from Arnold Kaplan this year was that about 98% of all stem cells injected, all progenitor cells injected, die. Either they die on implant or by apoptosis they're planned to die. And that seems to be across the field of stem cell research other than in the eye, which has been stunningly successful. So there's something about taking these cells and manipulating them that they don't like. The other thing is that we are finding that there may be a teaching phenomenon that goes on, that articular cartilage cells may teach other cells that come into that area how to behave like articular cartilage. And there's a whole collaborative process that we don't quite understand yet that I think is probably pretty exciting. And so I may leave you with one thought, and the thought is the same thought that I tell my kids, and that's that most of what we know is not true. And so if you're doing next year the same thing you're doing this year, you probably haven't learned anything. And so my feeling is that most of what I know here and most of what I do for my patients is probably not as good as I should be doing. And I try very hard every day to think about, how do I do these better? How can we improve on these? How do we look at something the way you just did and said, hey, look, you know, it might not be your cells, it may be just the way you're putting it in, dummy. You know, it could be something so simple. It could be so, you know, it could be really just looking at it from a different position or a different point of view that'll help you to see the work you're doing from a different light. And so I'd encourage all of you, especially those of you who are thinking about going to science or those of you who are in science already, it's a phenomenally fascinating field of orthopedic science, I think. It's hugely helpful to people. Most of what we know is probably not true. It's wide open for your input, and I'd strongly encourage any of you who have any interest at all to become as excited about it as I am.
That's an absolutely remarkable repertoire of techniques you've developed, Dr. Stone. Thank you so much.
You're welcome.
Now give it up for my dish. This job. Now give it up.